네, 안녕하세요. 대구 스마트치과 서구점의 이재욱입니다.
Greetings, I'm Dr. Lee Jae-wook of Daegu Smart Dental Clinic. Today I'm going to talk about immediate implant placement. The contents of the day. Necessity of immediate implant placement and preconditions for it. How extraction is going to be done needs to be considered, and how socket is going to be addressed. Finally, I'm going to talk about clinical cases and discuss how favorable immediate implant placements can be. Why is immediate implant placement necessary? What is immediate implant placement? It is a surgery that involves placing implant right after extracting tooth. In the area where extraction is done, the implant goes in. This is a procedure that is used by many dentists. According to various research results, there is no major difference between immediate implant placement and delayed placement where implant is placed on healed ridge. Histologically and histomorphologically, there's no major difference. If there's no difference, perhaps then you may decide to place the implant after healing is done. There's no difference in terms of results, but there can be many differences in the process. Let's look at the terms of immediate implant placement and delayed placement, which involves placing the implant in a healed ridge. Immediate implant placement refers to placing the implant right after extraction or within 1 week since extraction. After 6 weeks, then it is defined as early placement, and after 6 months since extraction, this is considered delayed placement where implant is placed on healed ridge. In general, we refer to placing the implant right after extraction or within 1 week as immediate implant placement. Why is immediate implant placement difficult? Why do many people think of it that way? People find it difficult because of these 3 factors. In the case of immediate implant placement, in the case of multi-root tooth, the implant shape and the root shape are not similar. Therefore, it's difficult to get the stability. How to get primary stability is an issue. Even if it is a single root, there's bound to be a gap. When there are such gaps, how to address them is an issue, and this is one of the factors that make immediate implant placement more difficult. Even if you have done immediate implant placement, how to address the soft tissue is another factor to consider. In the case of lack of soft tissue, you may have to do a lot of underlining significantly, and the level of surgery may become more extensive. If you get good primary stability, you do not need to worry too much of soft tissue. And I'm going to show why this is true with my case, which I'm going to show at the later part of the lecture. In immediate implant placement, the 3 factors that make it difficult. In other words, if you address these 3 factors well, then you can get good results with immediate implant placement. Personally, in my case, primary stability is a determining factor as to whether or not to proceed with immediate implant placement. How to get primary stability? I always think about how I can get primary stability when proceeding with immediate implant placement. This is the most important. In the case of healed ridge, even if primary stability is low, if you have a long resting period, then you'll be able to adjust it. But in the case of immediate implant placement, while the socket is healed, there can be bone resorption, so you need to have more primary stability compared with conventional treatment. Depending on bone quality and where we can get good primary stability needs to be determined. You need to understand this to be able to proceed with immediate implant placement more confidently. Rather than just blindly doing immediate implant placement because extraction has been done, you need to understand the bone quality and acquire more experience. Based on such know-how, you may proceed with immediate implant placement. In this case, because tooth form and implant form are similar, if there is sufficient bone below, then you can get sufficient primary stability. And you can have successful immediate implant placement. This is very important. In order to get primary stability, there are many factors to consider, but at least there needs to be 3 to 4 millimeter of residual bone. In the case of single root, it may resemble implant form, but there needs to be 3 to 4 millimeter of residual bone to provide primary stability. If this is lacking, you can get stability from septal bone or lateral bone. In the case of multi-root, if septal bone is sound, and if there is sufficient amount of bone below, of about 3 to 4 millimeter, then you may want to do bone graft, and if the gap is small, like under 2 millimeter, bone fill can occur in a natural way. As a result, you may have successful immediate implant placement. You always need to consider whether or not you can get primary stability. At times, we may not be able to get the primary stability we want. If the primary stability is lower than thought, then in the case of immediate implant placement, it can lead to failure. In certain cases, therefore, you may want to use a larger diameter implant or longer implant to get better primary stability. In this way, you may be able to get good primary stability. I've talked about how the results of placing implant in healed ridge and immediate implant placement are similar. The results may be the same, but in terms of healing period, there's difference. After extraction, there's a healing process, and then after implant is placed, there's once again another healing process. Therefore, although the results may be the same, if you do immediate implant placement, you may be able to get them faster. Immediate implant placement may be more favorable in this context. Clinically speaking, there are no major differences between the two methods, and this period is something that the patient needs to bear. And from dental clinic's perspective, providing the same result in a faster manner is better because you get more patient rotation. If you choose the right case and get good primary stability, then you'll be able to get more favorable results by doing immediate implant placement rather than delayed placement. This is another reason why immediate implant placement is favorable. In the case of healed ridge, the bone form is different from right after extraction. Labial bone resorption will occur inevitably, and when doing immediate implant placement, if you have done appropriate bone graft, then the results will differ with when there has been no bone graft and natural resorption has occurred.
차이가 날 수밖에 없습니다.
This is prerequisite of immediate implant placement. I've majored in maxillo-oral facial surgery, therefore I'm more confident about doing extraction compared with others.
다른 분들에 비해서 조금 더 자신을 가지고 이렇게 하는데
A traumatic extraction needs to be done to be able to place the implant in an immediate manner more comfortably. I've talked about one of the most important factors as being stability, and while you do extraction, if you destroy bony structure or if there's green stick fracture, then it may not be easy to get primary stability.
그린스틱 프랙처를 일으킨다든지 하시게 되면
Even if you have achieved primary stability, then additional procedures may need to be accompanied, and it can become more difficult. In the case of immediate implant placement, stability as well as a traumatic extraction are very important. You need to continue to hone your clinical technique on this end.
본인의 임상 테크닉을 자꾸 좀 갈고 닦으셔야 될 필요가 있겠습니다.
Basically, I tend to prefer elevator, but in the case of immediate implant placement, I use forceps. When I use forceps, I can minimize damage to the surrounding bone tissue. That's why I tend to use forceps for extraction. If there's no interdental space, inevitably I use elevator, and I try to make sure that I do not damage the surrounding bone tissue. More so than extracting other teeth, I tend to pay even more attention. On the slide, it says minimize risk of gingival trauma. When you use forceps, you hold the soft tissue together and do extraction, and inevitably the soft tissue becomes even less. Therefore, soft tissue protection needs to be done at times. More so than protecting the soft tissue, at times you grab the bone together and shake the bone. The most important factors for immediate implant placement is the fact that we need a traumatic extraction. Therefore, using forceps should be done very carefully. Depending on the way you move the tooth tends to come out. You should not use the forceps to pull on the teeth. Rather than pulling on the teeth, it's like a track and field athlete doing a high jump. The tooth should come out like this. In a natural manner, the tooth should be extracted. Rather than the surgeon pulling out the tooth, you need to help the tooth come out in the direction where it feels more natural. As if doing a high jump, the tooth should come out in a flexible manner. In the case of single root tooth, rather than pulling the tooth mesiodistally, you can effectively extract tooth by twisting it. In this kind of a case, if you pull on the tooth, the tip of the root is bound to fracture. And in order to remove the fractured tip, surrounding bony tissue may need to be removed. If that is not likely, undercut area may need to be removed, leading to inability to perform immediate implant placement. In this case, rather than pulling the tooth, you need to make sure that the tooth comes out naturally, and you need to use the forceps to guide the tooth. You need to check in which direction the tooth resists and in which direction the tooth comes out naturally as you do extraction. This is the same when using elevator if there's interdental space. Rather than using elevator first, use forceps first. This is similar to what you've just seen. When you apply elevator on the mesial side and the distal side, the way the tooth moves feels different, and on panoramic image or CT image, you need to check the direction of the tooth curvature and check in which direction the tooth is more likely to come out naturally. You need to do extraction as you get that sense. The absolute contraindication is applying elevator on thin buccal bone. If you do this, the tooth will not come out, but you may fracture the buccal bone or cause green stick fracture. You need to make sure that elevator is not applied to thin bony tissue. Even if there's no interdental space, in most cases, you have some room up to alveolar bone. If you remove the superior soft tissue and get a firm grip on the superior part of the tooth, by moving it mesiodistally and twisting it, you'll be able to do extraction. Using forceps is recommended. Let's look at the diagram. In most cases, extraction is performed like this. If there's no space to apply elevator, if you give a bit of indentation here, extraction can be done. Even in this case, if you remove the gingiva that is covering the root or do ablation slightly to expose the superior portion of the bone, then extraction will become more easier. When extraction becomes difficult is when you cannot really see it. By gaining visibility, then the same case would turn out to be much more easier. I've had such experience. By gaining visibility, you'll be able to notice that things will become more simpler. Gaining sufficient visibility and giving indentation will lead to easier extraction. If it is difficult to give indentation and if you do not want to damage the bony tissue, you can section the root. Using the root as a basis, buccolingually or mesiolingually sectioning can be done, but more so than the mesiodistal sectioning, it is more favorable to do buccolingual sectioning. If you do mesiodistal sectioning as you pull out the tooth, then force that cause green stick fracture can be applied to buccal bone, and therefore it is more ideal to do sectioning in a buccolingual manner. In the same sense, if the tooth is multi-root, you need to section the tooth so that each part has a single root and proceed with extraction. In the case of lower molar, this kind of fusion form is often observed. You need to divide it into two and proceed. If the tooth does not come out easily, you need to cut it like this. You need to section the tooth, but try to minimize damage to the bony tissue and proceed extraction in an atraumatic way. Once extraction is done, and if immediate implant placement is not likely, in other words, if there has been excessive damage to the surrounding bone tissue or soft tissue, and it is determined that it will be better to forego immediate implant placement, we need to perform socket preservation technique rather than leaving it as is healed ridge. This is to minimize bone resorption that can be of more help. If socket preservation is not done, as the extraction socket heals, bone resorption occurs, but if you do socket preservation, bone resorption can be minimized. Therefore, after attempting immediate implant placement first, if it is not likely, then you need to perform socket preservation technique to minimize bone resorption. The most famous technique of socket preservation is Moyen's bio-cold technique. Rather than an implant, you put in the bone graft and cover it with collagen membrane. On top of it, you may use ovate ponic, but this is not absolutely necessary. And if you can separate it, by doing this, you can minimize bone resorption, and when placing the implant later, you can do it in a much more easier way. If you're going to do immediate implant placement for the first time, rather than doing it in the multi-root case, where you need to get stability from septal bone or lateral wall, you should try it in a single root case first. This is a frequently observable case. The anterior tooth is fractured. In this case, there's no major damage to the soft tissue, and there's no suppuration or dental discharge. If there's no signs of inflammation, you can perform atraumatic extraction and perform immediate implant placement. Then it'll be of great help. To summarize about immediate implant placement, this is an already verified method. Compared with delayed placement, there's no major difference in terms of results. If you do bone graft, you can minimize bone resorption. However, if you just place the implant, it will not prevent bone resorption, and after doing immediate implant placement, you need to do appropriate bone graft. Then you'll be able to get good result. In the case of gap, if it is below 2 mm, then there will be natural bone fill because of jumping distance. If it is over 2 mm, then bone graft needs to be done to get safer results. In the case of immediate implant placement, instead of just listening to a lecture, if you look at various cases, it could be of help. As for a single root case, you may need to use the lateral wall to get more stability, and there are many different ways where we can do immediate implant placement. If you participate in the master course advanced surgery part as well, you'll be able to see more diverse cases and do hands-on practice to get more practical help. Thank you.